So I'm going to just go ahead and move on to our final presenter. Dr. Mary McMahon is from Cincinnati Children's here. She's a professor of pediatric physical medicine and rehab, and actually the chair of our rehab program. And clearly rehabilitation is tightly tied to the outcomes for severe traumatic brain injury, so we felt it critically important to end with this topic.
What a nice introduction. Thank you. I am really delighted to be here and to speak to you about what pediatric rehabilitation medicine has to offer children with brain injury. I have no financial disclosures, but I would note that unfortunately there's very little evidence to guide what we do in rehabilitation medicine. All the medications I'm going to talk about are off-label use in pediatric brain injury. So this is an outline of the things that I'm going to talk about, and I'm definitely going to stick to my 20 minutes and get through all these things. So it's going to be a broad stroke of what we have to offer patients. Starting in the acute setting, we really like to be involved in the ICU. We like to get there early. We like to get to know the families. We hope that we can help you identify some medical complications that are commonly seen in pediatric brain injury. I think the thing that we're most commonly consulted about is this autonomic storming or paroxysmal sympathetic hyperactivity. This is seen primarily in children with the most severe brain injuries. The incidence really isn't known because it depends on the population that you're looking at. It appears to be associated with a worse prognosis. There is no evidence-based guideline to help guide us when we use medications to treat this. Our own approach here at Cincinnati is typically, most of the kids tend to have significant tachycardia. So we like to start with propranolol and get that tachycardia under good control. Once we've obtained that, if they're still having hypertension, then often clonidine will be our next line agent. If they have associated dystonic posturing or muscle rigidity, we'll add an agent such as baclofen. And we like to keep these medications scheduled on a regular basis, but it's almost certain that the children will have breakthrough storming, if you will. So then we use PRN medications on top of that, whether it be Ativan, Valium, morphine. It's really a trial and error situation. Central fevers, I think fevers are very common in this setting, and often they are attributed to central fevers. And if you believe that it's a central fever, you should see it during that period of autonomic storming, and then it really should reside in between those spells. It's a diagnosis of exclusion. Pneumonia would be a common etiology for fever that we're always considering, but there's some other things that maybe aren't as obvious or common that you should always think about in the ICU setting, particularly DVTs. We've seen a fairly high relative incidence of pancreatitis, especially in kids with anoxic brain injury, but also traumatic brain injury as well. If they have a Folian, consider urinary tract infection, and always consider the CNS infections, especially if you've had surgery or an open lesion. We're screening for endocrinopathies, especially issues related to the sodium, and so watching the eyes and nose carefully. Just would note that sometimes these can rear their head even weeks after the injury, so you need to keep considering them in your differential. And then if a child is not getting better along the way, as you might expect, always consider subclinical seizures or the development of hydrocephalus that needs to be addressed. We do watch for immobility. Obviously, we want to pay close attention to the possibility for pressure injuries. Joint contractures are sometimes hard to avoid, especially if there's a lot of abnormal tone or asymmetry across the joint. So we'll start with early splinting and sometimes even go as far as serial casting in the acute setting. Passive range of motion, I think, is very, very important. And, in the best case scenarios, you might be able to get physical therapy or OT once a day in the ICU setting. But you have family members at the bedside that are often very interested in doing whatever they can to help their child. So if you can spend some time educating them on how to do the passive range of motion, I think you can get a lot more done. If we've done both of those and we're still concerned about losing range of motion and contractures, we'll look at medical management of increased tone. If it's generalized tone, considering oral baclofen or Valium. If it's more focal tone, we'll think about botulinum injections. Rarely would we consider intrathecal baclofen, but this has definitely been reported in the literature in the acute setting. Disorders of consciousness are quite frequent in children with very severe brain injury. We are there and hopefully can be helpful with doing serial exams and monitoring for the emergence of consciousness in these patients. What I would say in my 20 years of following these kids, that it's very rare if a child survives a traumatic brain injury that they don't exit out of the vegetative state. And in preparing for this talk, I actually can't think of a single patient that I've followed over the years who has remained in a vegetative state after a traumatic brain injury. We use medications to try to accelerate recovery. Historically, a lot of these medications were thought about to increase arousal, but in reality, I think arousal is not usually the biggest problem. What we're really trying to help is them be more responsive or more interactive with their environment. The dopaminergic agents have the best evidence behind them. Joe Giacino published a paper in the New England Journal of Medicine in 2012 that studied amantadine in the setting of adult traumatic brain injury. It was a very large international randomized controlled trial that did show that amantadine accelerated recovery versus placebo in the time that it was given. They did not have a pediatric population to pull out there to study, and the studies in children have been extremely small and not well controlled, more likely case series. We did do a small study here that was randomized and controlled, but it was primarily looking at safe dosing, and we found that 2 milligrams per kilo BID during the first week, and then followed up by 3 milligrams per kilo BID during the second week with a max of 200 BID seemed to be very safe and well tolerated by the patients. Other people have used bromocriptine as a dopaminergic agent and reported success in case series with that. I think that when you're considering these medications, we don't know the optimal dosing, we don't know the optimal timing of the dosing, and we really don't know the ideal candidates. What I would say is that it happens, the effect is very quick onset, and that within a week or two you should be able to tell if these medications are helpful or not, so that you don't have to have the children on these medications for a long term. GABA agonists have also been trialed. Zolpidem is the other agent that had a large controlled trial in the adult literature published by Dr. White. It's interesting in that they looked at using this medication in patients that were in a prolonged state, either vegetative or minimally conscious state, and when you gave the medication, they had a period of increased responsiveness that would last anywhere from 1 to 3 hours. But again, it was a small number of responders, less than 5% in that study. There have been a number of other non-pharmacologic interventions that have been talked about in the literature. Dr. Evanson published a nice review in the last year. These are, again, are primarily are really all case series or uncontrolled trials. So it isn't something that we're recommending our patients necessarily pursue, but some patients and parents feel that they really need to give their child every opportunity to have a meaningful recovery, and will pursue some of these interventions. And in that case, we just try to educate them about any potential side effects, including financial burden to their family if that's the case. But also just try to support them and understand why they feel the need to do that. Agitation is something that we see quite frequently after brain injury, thought to be secondary to injury to the frontal lobes or the limbic system. One thing, a word of caution, is just always to look for other etiologies that might be precipitating the agitation, such as some noxious stimuli, whether it's a missed fracture in the acute setting or development of, say, heterotopic ossification on a joint. Also to consider is drug withdrawal. We have to use a lot of sedating medications and pains for medication in the acute setting, and we do our best to figure out what is the appropriate taper, but sometimes it's a little bit quicker than the children tolerate, and so that might be another source of agitation. The duration of agitation is typically days to weeks. It generally always resolves spontaneously. As far as treatment, we try to regulate the child's sleep cycle, try to minimize environmental stimulation as much as possible, and then you can see there's a whole host of drugs that people have reported on and used in the setting of agitation. Again, there's not an evidence-based guideline. There's not really well-designed scientific studies to support the use of one over the other. But we, in general, try to avoid polypharmacy. We try to try one medication at a time, and so we can tell what's helping or not, and not just have a whole collection of drugs. Predicting recovery is something that I think we all wish we were better at, but we know that there's no single objective clinical, laboratory, imaging, or neurophysiological test that will reliably predict a neurologic outcome. And I think we've all seen children that surprise us, and we think that, that they can't possibly have a good recovery, and then they do. I think that it's best to talk to the families about the potential range of recoveries that are possible. Sometimes I think this is where your local physiatrist can be helpful, just because we do follow these children long term, so we get a good sense of that range of outcomes that's possible. Some families are accused of being unrealistic in regard to their hope for their outcome, and I think that oftentimes this is just a coping mechanism. I mean, this is a significantly traumatic event to have a child have a severe brain injury, and sometimes I think it's just their only way of surviving this incident is to maintain that hope, and I don't think it's necessarily our place to take that hope away from them. And in fact, we try to share in that hope with them and let them know that we are also hopeful with them. There are limited studies looking at predicting recovery, especially functional outcomes, which is what we focus on. We do know that children who make early progress also tend to make better ultimate recoveries, and that makes a lot of sense, I think, to most people. A lot of people think that if the younger you are, the better your outcome, that if you have a very young brain that maybe has a lot of neuroplasticity, that you can withstand a severe injury and do better. But actually the reverse is true, and young children, especially infants, tend to have a worse outcome after severe brain injuries. Dr. Suskauer at Johns Hopkins has done some nice work looking at markers for functional recovery, and she and her group has found that time to follow commands is a strong predictor, and is in fact the most useful injury severity variable for predicting functional outcome at 1 year. They found that time to follow commands less than 26 days is associated with a good long-term function as measured by the WFIM. So that doesn't mean that the child's going to have 100% recovery. It just means that they're going to have, can be expected to have a relatively good outcome as far as independence with ADLs and mobility. Dr. Wade here at Cincinnati Children's has spent the last 20 years studying social factors and their association with outcome of brain injury. She's followed a cohort longitudinally for many years with an orthopedic control, and has found that permissive parenting, strict and controlling parenting, a less advantaged home environment, when you control for other factors, will have a negative effect on the child's outcome. And Dr. Ryan also showed that poor caregiver mental health also affects or is associated with a poor outcome. So we do think it's important to pay close attention to the family and the social environment, and try to improve its functioning as well. So just in summary, there's a lot of things that we work on in rehabilitation medicine and to promote functional recovery, including minimizing sedating medications, trials of neurostimulants. We like to begin therapy early in the ICU as soon as the patient's medically stable and felt to survive their injury. We spend a lot of time educating the family. We are believers in inpatient rehabilitation program, and we also follow the patients long term for coordinated outpatient follow-up. Just wanted to mention briefly that therapy services such as OT, PT, and speech do not equal in our mind a comprehensive rehabilitation program. This is our rehabilitation team here at Cincinnati Children's. We, of course, have the patient and family at the center of the program. Our team is led by a physiatrist, and then we have OT, PT, and speech therapy services involved with our patients. We have a care manager who works with the insurance company to get pre-authorization and make sure that the care or the stay is continually supported by the payer, and then they help with discharge planning, with equipment and follow-up appointments. We have a social worker who helps the family with coping and the things that we just mentioned earlier. We have psychology. We use them. We have different psychology services. We have a behavioral psychologist that helps with behavior programs when they're necessary and supporting the families again and the patients. Then we have neuropsychology that helps monitor the child's cognitive recovery and does a more formal screening prior to return to school. We utilize therapeutic recreation where they look at our team's goals in the recreational setting, and they also take the children out into the community to practice their goals. We have a certified music therapist who also works on the therapeutic goals. And then we employ school teachers as part of our team that their sole responsibility is to help integrate the child back into the school setting. We'll do things like Skype with the children's class with the patient. We will do peer-in services at the schools. We will go out to the schools and meet with the schools, with the families, and help them be good advocates for their child. I know that many centers don't have the luxury of having a rehabilitation program or unit on site, but if you don't and you have a child who has a really severe injury and is not having a quick functional return to their baseline, I would encourage you to consider and look for opportunities for children to take advantage of a rehabilitation program. There's freestanding and acute care facilities or programs that are based at acute care facilities. You can, as far as looking at some potential quality metrics, you can see if they're CARF certified. There's pediatric specialty program certification. There's additional brain injury specialty certification that they can obtain. You can inquire to see if pediatric physiatry is available. By definition, we're all certified in PM&R, but we also may have additional certification in pediatric rehabilitation medicine. And then there's a newer certification that's been out for about 3 years. It's a joint project between the American Board of Physical Medicine and Rehabilitation, as well as the American Board of Neurology and Psychology and Family Medicine for sports and concussion management, where with additional training, people can become certified in brain injury medicine. I've listed a lot of references in my talk. If you would like a more complete list, I'd be happy to have you email me and I can provide them for you. Thank you.
That was great, Mary. I want to first, before we kind of open it up to questions, really thank all of our presenters this afternoon. It's been, in my opinion, a great afternoon of learning and discussion, especially those both here as well as those online that have been able to join us.